Now let's welcome Dr. Alika Lafontaine, anesthesiologist and president of the Canadian Medical Association, to talk about the role of tech on Indigenous healthcare.
It's great to join you for your conference today. My name's Alika Lafontaine, and I'm an associate clinical professor from the College of Medicine at the University of Alberta. My presentation will be on whether digital health adoption will lead to greater health equity, a question that I know underlies any type of system change that we make for our communities or our territories. I'll share a little bit about me. I was born and raised in Treaty 4 territory in southern Saskatchewan. My ancestry is Métis, Cree, Anishinaabe, and Pacific Islander. I'm an anesthesiologist, and I've practiced in rural Alberta for more than 10 years. I've held leadership positions with national medical organizations, including the Canadian Medical Association. In the fall, I'll become the first Indigenous physician to serve in the presidency years in its 154-year history. I sit on the council of the Royal College of Physicians and Surgeons of Canada, and I've been on the board of Healthcare Can, who's responsible for coordination of hospitals and academic research. My own personal research focuses on the intersection of anti-racism, reflective practice, and working environments, and how that all influences patient care. I've been involved in health transformation projects for more than 2 decades, including many recent task forces on virtual care and digital health adoption, and I'm pleased to be sharing some of the things that I've learned over the past few years about some of the challenges and decisions that you'll be faced with in coming years. What I'm hoping you'll get out of this presentation is a bit of a discussion on how bias and discrimination impact equity in healthcare. We'll review some digital health definitions. We'll discuss how equity can be affected by digital health tools, and hopefully provide some strategies or some ways to think about the decisions that you'll be making moving forward. The first part here about bias and discrimination really touches on this idea that there's a world out there that we don't see. In medicine, there's this term called scotoma, which refers to a partial loss of vision or blind spot in an otherwise normal visual field. Now, this can be due to a lot of different reasons, including neuromuscular diseases like strokes. You could have neurodegenerative diseases that you were born with or that you acquired, or you could have been in an accident where something happened and you developed this blind spot. I'm going to go through an exercise here, and because we're not seeing each other face to face, I just want you to reflect yourself on the outcomes of this exercise. But I'm going to put a paragraph up on the screen, and I'm going to invite you to count the F's within the paragraph. And I'm going to ask you how many F's you saw at the end of the exercise. So I'll put up that paragraph right now, and we'll have you count those F's. And I'll give you 3 seconds. 1, 2, and 3. So the question is how many did you see? So first I'll have you consider whether or not you saw 3. And if you saw 3 and there's a live chat, I'll just invite you to type that in so the rest of the participants can know what you saw. If you saw 4, I'd invite you to put that into the chat as well. And if you saw more than 4, I'd invite you to put in the number of F's that you saw. Now here are the actual F's within the paragraph. Finished files are 2, are the result of years of, that's 4. Scientific 5, study combined with the experience of years, that's 6. So when I present this exercise across the country, and I have for quite a few years, there's the same sort of reasons why people don't see F's within the paragraph. The first is that we often read aloud in our heads. And because we read aloud in our heads, sometimes the sounds don't line up the way that we expect. The sound of scientific sounds very different than the sound of. The second is, although I gave you the task of reading for content, even though you were assigned that task, you still do what you're normally used to doing. And I expect a lot of people were reading through the paragraph and considering what the content was about. What was the paragraph really about? The third is that we often skim to be efficient. So big words like scientific often trigger the idea that it's content. And small words like of to us maybe seem like filler. And so for these three reasons, often people don't see the F's. Now I'm going to have you go through another exercise, which is reading the triangles. All right, and I'm just going to have you read them from left to right, and I'll just ask that you read them within the time that I'm going to give you. So I'll have you read the left triangle, the center triangle, and the right triangle. And that's about 3 seconds that I've given you. Now I'm going to have you read them again, and I want to know whether or not you saw what was really there. The first triangle says Paris in the spring. The second triangle says once in a lifetime. And the third says bird in the hand. Now what's interesting is that that trick was pretty much the same as the one that you were presented with counting the F's. And for many people who go through this exercise, they don't see what's in the triangle as well. And the reason why is because there really is a world out there that we don't see. Scotomas aren't just physical, they can also be intellectual. And they're an inability to perceive distortions in perception that are often very obvious to others. And although when I often talk about this, I root it in social interaction or institutional structure, the reality is that when you're designing digital tools and creating applications in the area of digital health, these blind spots are extremely important. I'm sure many of you have seen this graphic. It talks about equality, equity, and justice. Now, equality is the assumption that if you give everyone the same thing, that they'll all benefit from the supports and that they all should more or less be able to do what they're doing because they need to come up with the rest of what they need. If people don't have access to certain things because they're getting equal amounts of funding or equal amounts of human resources and their need is greater, equality often leads to very bad outcomes relative to those who need higher boxes to stand on. Equity, on the other hand, is this idea that you give people what they need. And you give them higher boxes if they need that to see over the fence. Now, the third concept of justice is the idea that if you remove the barriers within the system, you actually don't need the boxes to begin with. And this is probably the most powerful concept out of the three for creating equity within health systems. Within health, we really operationalize these concepts of equity within different ways that we approach designing systems. So this is the triple aim of health equity. It's a very common graphic that's shared when talking about health system design from the Institute of Health Improvement, one of the large organizations that sets standards for health within mainstream healthcare systems. And it talks about three parts: implementing health in all policies, strengthening community capacity, and expanding understanding of health. Now, the question I have for you is that if bias and discrimination are present as people create these designs, what do you think they won't see? In digital health, we define it as the use of information technology or electronic communication tools to do services and processes as we deliver healthcare and facilitate better health. Virtual care is a part of digital health. It's a more specific interaction between patients and members of their care team, and it's often remotely. And this uses any types of form of communication, telephone, video conferencing, etc., with the aim of facilitating or maximizing the quality of patient care. Within this graphic, you can see how digital health encompasses virtual care. And when we talk about things like telehealth, which can be things more than just seeing your doctor, it could be texting your psychologist about your mental health. It could be connecting with a physiotherapist who walks you through how to do certain exercises. It includes many different types of care. You could have AI diagnosis where you send in a picture and in response you have a computer tell you what your rash is. It could be telemedicine where you connect with the physician who may or may not be from or around the place where you live. It could augment the decision-making abilities of the providers who provide you care. Secure messaging, EMR systems, being able to get prescriptions through telepharmacy, all of these things are encompassed within virtual care. But within digital health, it's much broader than that. These include things like AI-driven research, patient forums that you can connect to online to have other people who experience the same sort of chronic pain conditions or chronic disease that you do, using artificial intelligence and machine learning for disease modeling, or one of the things that I'm involved in, which is anonymous patient complaints. So digital health and virtual care are two different things, and they encompass different scopes. When we look at the goal of all of these different tools in order to bring us to this end goal of health equity, I split the different approaches into three broad categories: small data, big data, and future applications. So small data is really tools that rethink the existing infrastructure and workflows that you use. More efficient ways of managing the people who work in your locations, so AI schedulers, or different ways for people to connect using those tools within their clinical practice. So things like remote medicine or connecting people by phone instead of having them to come into the hospital. Big data, on the other hand, is tools that take large data sets and use them to create patterns and make decisions. While the third approach, the future applications, are often these tools that we have yet to imagine or consider. So equity is achieved through these tools. Well, it depends. So if you look at tools that rethink existing infrastructure and workflows, things like virtual care, telehealth, telemedicine, and telepharmacy, the implementation of digital health is very highly dependent on the environment in which you place it. If you have an environment that doesn't have any existing infrastructure, it becomes very difficult for these types of tools to circle back and provide full scope of care. Things that are more effectively done in person could be things like physical exams, blood work, surgical interventions, or if someone's extremely sick or runs into a medical emergency, resuscitation and emergency treatment. While virtual care can be very effective at expanding what you have or making it more effective, in and of itself, it's not a health system. It's simply an extension of what you have right now. And so it's important that as we think through these tools, that we don't assume that implementation will necessarily lead to equity. There's a series of questions that you can go through in order to figure out whether or not you can maximize the impact of digital health. Different things that you could look at are auditing your resources. So what do you have right now that meets your community needs? And how do you meet them? Do you have enough family physicians or access to family physicians? Do you have nurse practitioners? Do you have access to primary care versus specialty care? All of these things fit into the auditing and then understanding your community needs and how they're met right now. The next part that I'd suggest looking at is matching the needs of your community with the digital health solution. So when you're looking at something like virtual care or something more specific like telemedicine or telepharmacy, is that a need that's been expressed or that you can see in the way that things work right now? And in the context of how the other needs are met in person, or the other digital health tools that you use, does it make sense how that fits in? One of the things that we often overlook when we're looking at digital health is really considering a data sovereignty strategy. Patient data and protection of that data is really something that we don't often plan around. It's something that is often lower priority just because we're overwhelmed with the current demands for health care and health tools that we need right now. But if you don't plan for this data sovereignty, often someone else is planning it for you. And so it's important to kind of think through how this applies within your context. And finally, evaluating safety and quality is extremely important. So digital tools often minimize the roles of people. And software is designed around the bias and discrimination of the people that program it. And so the real take-home message from today is to remember that digital health and all of the things that become more specific within telehealth and telemedicine and all the other applications that I mentioned, they're simply tools to achieve equity, and you need to decide if they deliver on the promise of equity or not within your specific context. In order to figure out whether or not those apply, these are some principles that you can consider as you come to understanding your own local context. It was a pleasure to present to you today, and hope that this helps you in your journey to reach that point where you can decide what's best for your communities and territories. Thank you.